Failure to thrive is a term that is traditionally used for children who have failed to develop and grow normally. In general practice, failure to thrive is commonly used for any child who fails to gain weight or height according to standard growth charts. Failure to thrive occurs when a child is either not receiving adequate calories or unable to properly use the calories that are given, resulting in failure to grow or gain weight over a period of time. Using standard growth charts, a child's weight or height below the third percentile for age, or a progressive decrease in the rate of gain of height or weight, should be considered as failure to thrive. The physiologic basis for failure to thrive is inadequate nutrition, and it is divided into organic, inorganic, and mixed failure to thrive. But most cases of failure to thrive are mixed. Organic failure to thrive is gross failure, which is due to an acute or chronic disorder that interferes with nutrient intake, absorption, metabolism, or excretion, or that increases energy requirements, such as illness of any organic system can be a cause. Children with organic failure to thrive may present at any age depending on the underlying disorder. Non-organic failure to thrive is due to insufficient calorie intake. It usually manifests first as failure to gain weight, and growth in lunges and head circumference remain normal for a period of time until they too become impacted by poor calorie intake. This is the most common pattern of non-organic failure to thrive. Most children with non-organic failure to thrive manifest growth failure before age 1 year and many by age 6 months. When non-organic failure to thrive is caused by psychological factors, growth failure accompanies or precedes poor weight gain. This is thought to occur because mental stress in the child might cause increased level of counter-regulatory hormones such as catecholamines, steroids, which oppose the effect of growth hormone. Up to 80% of children with growth failure do not have an apparent growth inhibiting or organic disorder, and growth failure occurs because of environmental neglect, lack of food, or stimulus deprivation, or both. There is no growth inhibiting or organic disorder that cause growth failure. Lack of food may be due to poverty, poor understanding of feeding techniques, improper preparation of formula, such as over-diluting formula to stretch it because of financial difficulties, inadequate supply of breast milk because the mother is under stress, exhausted, or poorly nourished. And the non-organic failure to thrive is often due to disordered interaction between a child and a caregiver. In some cases, the psychological basis of non-organic failure to thrive seems similar to that which occurs in infants who are hospitalized for an extended period who develop depression secondary to stimulus deprivation. The unstimulated child becomes depressed, apathetic, and ultimately anoxic. Stimulation may be lacking because the caregiver is depressed, has poor parenting skill, is anxious about or unfulfilling by the caregiver role, feels hostile towards the child, is responding to real or perceived external stresses, such as demands of other children, large or chaotic family, marital dysfunction, significant loss, and financial difficulties. Poor caregivers does not fully account for all cases of non-organic failure to thrive. The child's temperament, capacities, and response help shape caregiver nurturance patterns. Common scenario involve parent-child mismatches in which the child demands, such as difficult feeder, although not pathologic, cannot be adequately met by the parent, who might, however, do well with a child who has a different needs or even with the same child under different circumstances. A difficult feeder might uncover a problem with parent-child interaction that would have remained hidden if the child were an easy feeder. The other type is mixed failure to thrive. Mixed failure to thrive, organic and non-organic cause can overlap. For example, children with organic disorder also have disturbed environments or dysfunctional parental interaction. Likewise, children with severe undernutrition caused by non-organic failure to thrive can develop organic medical problems. Mixed failure to thrive is the most common type of failure to thrive. To diagnose failure to thrive, especially in children, age should be plotted against weight, height, and head size on growth standard and growth charts, such as WHO growth chart. Weight is the most sensitive indicator of nutritional status. Another useful measure of undernutrition includes a body mass index, Z-score of less than -2, and when failure to thrive is due to inadequate calorie intake, weight falls from baseline percentile before longest does. Reduced linear growth usually indicates severe prolonged undernutrition. Simultaneous fall of length or height and the weight suggests a primary disorder of growth and a prolonged inflammatory state, because the brain is preferentially spared in protein-energy malnutrition. Reduced growth in head circumference occurs late and indicates very severe or long-standing undernutrition. Children who are underweight might be smaller and shorter than their peers and may present with fussiness or crying, even lethargy, sleepiness, and constipation. Failure to thrive is associated with physical delays, such as sitting and walking delay, social delay, interacting learning is delayed, and if occurring in older children, delayed puberty. So, to diagnose failure to thrive, growth chart is very important. The primary tool used to diagnose failure to thrive is by plotting a child's weight and height on standardized chart, looking for measurements falling significantly below the expected range for their age and gender. A single measurement is not enough. A diagnosis is usually made by observing a consistent pattern of poor weight gain or decreased growth velocity over multiple visits. In addition, a healthcare provider will discuss the child's feeding habits and the dietary intake to identify any potential nutritional deficiency or feeding issues. And a thorough physical exam is conducted to assess the child's overall health and to look for potential underlying medical cause for growth delay. Extensive laboratory testing is usually not productive. If a thorough history and physical examination does not indicate a particular cause, most experts recommend limiting screen tests to complete blood count with differential, ESR, renal function test and electrolyte, urine analysis and culture, stool for pH, substance such as reducing substance, odor, color, consistency, and fat content, and also depending on prevalence of specific disorder in the community, blood lead level, retroviral infection, or tuberculosis testing might be warranted. Testing for endocrine disorders that can impact growth is sometimes appropriate. Hyperthyroidism may result in weight loss, and testing includes T4 and the TSH, and also growth hormone assessment, which is done by measuring fasting blood levels of insulin-like growth factor 1 and insulin-like growth factor binding protein type 3. When growth is high in height is more severely affected than growth in weight, or when height for length and the weight falls off simultaneously, you should have to do growth hormone assessment. Testing for celiac disease might be done as part of initial evaluation. Testing might include the serologic marker, anti-tissue transglutaminase antibody, and the anti-endomysial antibody, and sometimes small bowel biopsy. Investigation for infectious disease should be reserved for children with evidence of infection, such as fever, vomiting, cough, and diarrhea. However, a urine culture may be helpful because some children with failure to thrive due to UTI lack other signs and symptoms. Cardiologic investigation should be reserved for children with evidence of anatomic or functional pathology, such as pyloric stenosis and gastroesophageal reflux. However, if endocrine cause is suspected, bone age is sometimes determined. Treatment of failure to thrive is aimed at providing sufficient health and environmental resources to promote satisfactory growth. A nutritious diet containing adequate calories for catch-up growth, that means about 150% of normal caloric requirement, and individualized medical and social support are usually necessary. Ability to gain weight in the hospital does not always differentiate infants with non-organic failure to thrive from those with organic failure to thrive. All children grow when given sufficient nutrition. However, some children with non-organic failure to thrive lose weight in the hospital, highlighting the complexity of this condition. For children with organic or mixed failure to thrive, the underlying disorder should be treated quickly. For children with apparent non-organic failure to thrive or mixed, management includes provision of education and emotional support to correct problems interfering with the parent-child relationship, because long-term social support or psychiatric treatment is often required. The evaluation team may be able to only to define the family's needs, provide initial instruction and support, and institute appropriate referral to community agencies. The parent should understand why the referrals are being made and if option exists, should participate in decision concerning which agency will be involved. Prognosis for organic failure to thrive depends on the cause. With non-organic failure to thrive, the majority of children aged greater than 1 year achieve a stable weight above the third percentile with appropriate management. Children who develop any type of failure to thrive before age 1 year are at high risk of cognitive delay, especially verbal and math skill. Children diagnosed at age less than 6 months, when the rate of postnatal brain growth is maximal, are at highest risk. General behavioral problems identified by teachers or mental health practitioners occur in about 50% of children. Problems specifically related to eating, pickiness, slowness, or elimination tend to occur in similar proportion of children, usually those with other behavioral or personal disturbance. In summary, failure to thrive is weight consistently below the third percentile for age and gender, progressive decrease in weight to below the third percentile, or a decrease in 2 major growth percentile in a short period. Organic failure to thrive is due to medical problems, and non-organic failure to thrive is due to psychosocial problems. In addition to taking a thorough medical, social, and dietary history, healthcare providers should observe parent and caregiver feeding the child. Hospitalization might be necessary to evaluate the child, to observe the child's response to appropriate feeding, and to involve a feeding team if needed. Thank you for watching.